Okay, good morning, everyone. We are now going to start day 2 of the ICD-10 Coordination and Maintenance Committee. For those of you who were not able to join us yesterday, there were no procedure proposals yesterday, so we covered off a pretty fair number of diagnosis proposals yesterday, and today we have 16 remaining topics that we will cover today. Again, the deadline for comments for proposals presented at this meeting are in your timeline, but I believe it's November 13. And the deadline for receipt of new proposals for consideration for the March 2018 meeting is January 8th. And also, in your topic packet, you have most of the proposals, but when I said 16, I saw some eyebrows go up, and that's because we have 3 additional topics that are not on your agenda. That material will be posted shortly after this meeting ends, but we will be covering the information and you'll be seeing it on the screen. But again, the posting will go up shortly after the meeting, just so you know. It's not fuzzy math. With that, I am now going to turn the podium over to, is it you, Cheryl? Okay. To Cheryl Bullock, who will lead us in the discussion of the first topic. Cheryl.
Good morning. This morning, for our first presentation, we do have a guest speaker, and we will be addressing the Duchenne muscular dystrophy proposal, and it is found on page 35 of your topic packet. I'd like to introduce Dr. Catherine Wagner. She is the director of the Center for Genetic Muscle Disorders at the Kennedy Krieger Institute. Dr. Wagner. You have to point at David.
Point here?
Yeah, to like, he's
Oh,
good.
I see,
Yeah,
okay, forward?
Yes,
And
ma'am.
this
We're gonna try it.
is the pointer?
Yes.
Okay, great.
I think that's right.
All right, great. Well, thank you very much. I appreciate the opportunity to speak to you today about new ICD-10 codes for Duchenne and facioscapulohumeral muscular dystrophy. Whoops. Okay, so there are several major types of muscular dystrophy with dozens of subtypes. The 4 most common types of muscular dystrophy are Becker, Duchenne, facioscapulohumeral, and myotonic muscular dystrophy. I don't think I have a pointer, maybe. Doesn't look like it's working. Oh, it is very brief. Yeah, it is. Okay. These are the prevalence of these disorders. Now, myotonic muscular dystrophy already has its own ICD-10 code, and we're proposing to create new codes for Becker, Duchenne, and facioscapulohumeral muscular dystrophy. Duchenne and Becker are caused by mutations in the same genes, and they share symptoms, except the symptoms in Duchenne start earlier and are more severe than in Becker. Therefore, both muscular dystrophies could have a common code. So first, Duchenne and Becker muscular dystrophy. So Duchenne and Becker develop when dystrophin is missing or malformed. Dystrophin is a large protein underneath the muscle membrane that holds intact a complex that helps communicate the outside of the muscle to the inside of the muscle membrane. And when this is lost, there is loss of a function in the muscle. Duchenne is an X-linked disorder affecting 1 in 5,000 live births. They're usually diagnosed before the age of 5. They lose ambulation before age 13, and they die in early adulthood due to cardiac or respiratory disease. This is a schematic of the natural history of Duchenne muscular dystrophy, showing that the progress that we've made over the years, where now diagnosis occurs much earlier than in previous decades, and loss of ambulation occurs later, and other milestones such as the need for ventilation and death occur later in life. There's a loss of clinically meaningful milestones which occur in a predictable order. These are ambulatory milestones such as ability to hop, jump, run, the Gower sign when standing, etc., and non-ambulatory milestones. The CDC and the community of neuromuscular clinicians have created standards of care that are specific for Duchenne, and these have been published in Lancet Neurology, and new care considerations are coming out in Lancet Neurology. These specifically discuss the management, the diagnosis and management of Duchenne muscular dystrophy as a multi-system disorder. Specifically important is the use of corticosteroid management, which is specific to Duchenne and is not used in the other muscular dystrophies. There are a number of clinical trials in development for Duchenne using a variety of different therapeutic targets. And this slide just shows a large number of trials that are currently involved in Duchenne muscular dystrophy. This is also relatively specific for Duchenne, as there are very few clinical trials in the other muscular dystrophies. This shows the first two drugs that have been granted FDA approval just within the last year for Duchenne muscular dystrophy. Now, Becker's muscular dystrophy is a variant in which there is dystrophin deficiency also resulting from DMD gene mutations. Becker muscular dystrophy shares the same symptoms as Duchenne, but with a variable phenotype. The loss of ambulation is in late teenage to mid-life. There are also no treatment options for Becker muscular dystrophy. Cardiac symptoms can be severe in Becker muscular dystrophy. Now I'd like to turn to facioscapulohumeral muscular dystrophy, which is a very distinct disorder. So this is an epigenetic disorder. The prevalence is 1 to 8,000, 3,000 to 1 in 20,000. It's an autosomal dominant disorder affecting men, women, and children. This shows an affected mother and her child. It's linked to the distal end of chromosome 4q, and it's not a monogenetic disease such as Duchenne, but an epigenetic disorder. In this disorder, there are contractions in the 4q chromosome, leading to hypomethylation of this region and the inappropriate expression of a transcription factor, DUX4, that leads to a toxic DUX4 protein being produced. Very separate pathophysiology than in Duchenne muscular dystrophy. Normally, people have an integral number of these D4Z4 repeats, 11 to 100. In about 95% of FSHD patients, there's only 1 to 10 repeats. In early or infantile onset, there are 1 to 3 repeats, and in mild reduced penetrance, there are 8 to 10 repeats. There's a wide variability of severity. The majority of patients present in adolescence or early adulthood with asymmetric shoulder girdle weakness. Here you see the loss of pectoral muscles, and here you see the loss of muscles of scapular fixation, leading to winging of the scapula. There's facial weakness with a transverse smile, as shown here, and an inability to fully close the eyes, as shown here. Pelvic girdle, foot, dorsiflexor, and abdominal muscle weakness may follow. There's usually no extramuscular disorders. There is an early or infantile onset FSHD. This leads to rapid progression with loss of ambulation and is associated with retinal vascular abnormalities and high tone hearing loss. This is more likely to be associated with respiratory insufficiency. In FSHD, there's a variability in the phenotype and in the needs from the early infantile onset to a very late, mild onset and presentation. The clinical care of FSHD has not been as studied, and there are not guidelines as there are for Duchenne. However, there are generally recognized clinical care standards, such as for the infantile onset, those dealing with vision, hearing, and pulmonary, and for all dealing with the skeletal muscle asymmetric weakness, progressive and irreversible weakness. This is an individual showing who has had scapular fixation, a surgery to fix the scapula to the rib cage so that there is not winging of the scapula when the arms are abducted. Assigning individual ICD-10 codes to the most common types of muscular dystrophy will facilitate the surveillance of these diseases, allow more accurate estimations of their incidence, prevalence, and survivorship, allow for tracking of mortality and its causes, injuries, symptoms, and health visits, help to identify factors that influence health status and secondary conditions, be used to compare health information across hospitals, regions, clinical settings, countries, and even across time in a given location, serve to track reimbursements, and what I think is really the most important is to facilitate the evaluation of guidelines, implementation, adherence, and impact of the care considerations that have been published by the CDC. These are the global advocacy organizations that are supporting this ICD-9 nomination, ICD-10, sorry. And the neuromuscular clinical community overwhelmingly supports this nomination. Thank you very much.
Thank you, Dr. Wagner. Do we have any questions, any clinical questions for Dr. Wagner at this time from the floor?
Jeff Linzer, American Academy of Pediatrics. We have had the opportunity to review this proposal and support its addition for surveillance and epidemiologic tracking of these disorders.
Thank you, Dr. Linzer. I will go ahead and present the code proposals, and then we will open up the phone lines for any clinical and coding questions. So you can stay. You can stay.
Stay here.
Yes, ma'am. Okay. The code proposal is as follows. For at category G71, primary disorders of muscles, it is being proposed that at G71.0, muscular dystrophy, basically it's being proposed that all of the inclusion terms will be deleted. These inclusion terms that are going to be deleted will be expanding under the proposed categories, specific categories. At new code proposed, G71.01, Duchenne or Becker muscular dystrophy, with inclusion terms of autosomal recessive childhood type muscular dystrophy, the benign Becker muscular dystrophy, or severe Duchenne muscular dystrophy. For new code G7102, facioscapulohumeral. It's the code for G71.02 with inclusion term scapulohumeral muscular dystrophy. At proposed new code G7108, all remaining deleted inclusion terms will be under this code. And last, the new code G7109 will be muscular dystrophy unspecified. Are there any questions from the floor regarding this code proposal? Yes. Moderator, could you open the phone lines for any clinical or coding questions, please?
All lines have now been unmuted.
Are there any comments or questions from the phone lines?
Can you hear me? Hello, this is Dr. Reamer. Can you hear me?
Yes, ma'am.
Hi, good morning.
Good morning.
So I am not clear, why are we not making a code for Duchenne and a code for Becker? It seems like there are treatments that are specific for Duchenne that they don't use for Becker, so it seems like having that kind of specificity might be important for their epidemiological and research.
Do you want?
Can we have Annie Kennedy from the floor answer that question?
Hi, I'm Annie Kennedy with Parent Project Muscular Dystrophy and been helping lead this effort. We've been working on this effort for about 2 years, and we've been working with the scientific and clinical community. And the issue is that we couldn't come to consensus with the clinical and scientific community around where the cutoff for Duchenne and Becker was. So we could come up with different clinical definitions of the cutoff and different scientific definitions of the cutoff. But what we got to in agreement was that they are really a trajectory of the same dystrophinopathy. So where the community was comfortable was for the purposes of what codes were used for, having one shared code for Duchenne and Becker, and then moving forward with that proposal.
Thank you. Dr. Reamer, did you hear that?
I sure did. And if that's what they want, it just seems like if they have specific treatments for one versus the other, then they might want to be able to follow whether a treatment works. And, you know, it would be dependent on how people document, obviously, whether they would go into one or the other. But if they don't want it, who am I to argue with them? Thanks.
Thank you. It's an important question to us. The issue is in the lifetime of someone with Duchenne or Becker, their diagnosis sometimes changes right now between Duchenne or Becker depending on their phenotypical and genotypical presentation.
Okay. Thank you. Are there any other comments or questions from the phone lines?
Yes, please. I have a comment.
Okay.
Well, two things. First of all, the proposal is very nice, but the unspecified should be G71.00, fifth digit 0 is unspecified. And you can always carry the G7101 out to the 6th character if they want some more specificity at that particular code.
Thank you for making... So noted. Thank you. Any other comments or questions? Not hearing any. Thank you very much. Thank you. I'm turning over the podium to Tracy.
Good morning, everyone. I'd like to introduce Terry Moncava, who has been with the Williams Syndrome Association since 1990, serving as a regional director, board member, board president, and executive director. Today, Terry will give the presentation on Williams Syndrome. Terry, would you like to come forward? These can advance. You just have to point it to the computer down there.
Okay. Great. Good morning, everyone. I apologize that I'm not a doctor. Dr. Pober, who is our clinical professional and who helped me create this proposal, was not able to be with us today. So I will do my best to do this presentation and to also answer questions. I have a 31-year-old son with Williams syndrome, so I have been around him for 31 years and also hundreds of others through my association with the Williams Syndrome Association, the national support group. Williams syndrome is currently without a specific ICD code. Due to the numerous symptoms and affected body systems, individuals with Williams syndrome are typically given various nonspecific codes relating to chromosomal deletions or congenital abnormalities. Williams syndrome was first recognized in 1961. It's a multi-system disorder known to occur in about 1 in 10,000 individuals. That's approximately 25,000 in the United States. Williams syndrome affects both males and females in all cultures with medical, developmental, cognitive, and neurological challenges. And although no formal studies have been undertaken to date, life expectancy is thought to be shorter, perhaps as much as 5 to 10 years than for the general population. And this is due primarily to the early aging effects of the elastin deletion, but it also can be impacted by several medical issues, primarily cardiovascular and gastrointestinal, which can also shorten lifespans for those with Williams syndrome. Williams syndrome is caused by a microdeletion on one copy of an individual's chromosome number 7. The deletion is just 0.1% of an individual's genetic makeup, but it causes many challenges. And if any of you have ever known anyone with Williams syndrome, you know that it also causes a few distinct gifts. The Williams syndrome critical region is a 1.5 megabase deletion of 26 to 28 genes on the long arm of chromosome 7. And that identical deletion occurs in about 95% of individuals with Williams syndrome. The critical area is shown here in light blue. A smaller number, fewer than 5%, will have a longer deletion, which is usually 1.8 megabases, or a shorter deletion of varying size. The longer deletion often results in seizure disorders and a lower measured IQ, while those individuals with the smaller deletion often have higher IQs, better spatial skills, and also a better grasp of social nuance. As I mentioned before, Williams syndrome is a multi-system disorder. It presents challenges throughout the lifespan, and there is potential for problems in many different body systems. Oops, sorry. Some of the more common issues are supravalvular aortic and pulmonary stenosis, strabismus, small, widely spaced teeth, high, narrow palates, hypercalcemia, growth issues, reflux, constipation, diverticulosis and diverticulitis, malformed or missing kidneys, scoliosis, kyphosis, lordosis, Chiari malformations, and social emotional problems, including anxiety, depression, and phobias. Most troubling and widespread of all the issues in Williams syndrome are the cardiovascular anomalies. These occur in 75 to 80% of individuals and range from mild to life-threatening, sometimes leading to sudden death. Virtually all individuals who have cardiovascular issues will have one or more forms of stenosis, usually aortic or pulmonary, but also sometimes carotid or coronary. And most who experience cardiovascular issues will have them become apparent in their first year of life. Surgery, sometimes multiple surgeries, are required in about 35% of individuals with cardiovascular issues. And usually they will occur before age 5, although surgery can become necessary at any age. Supravalvular aortic stenosis, shown here, is the most common issue in Williams syndrome. The narrowing, which results in issues much like those seen in adults who have in the general population. However, rather than being caused by plaque, like for those in the general population, the issue of stenosis in Williams syndrome is caused by a smooth muscle overgrowth, which happens due to the elastin deletion. Other vascular narrowings, which are less common but also very troubling, can occur in the celiac and renal arteries. And these will often lead to chronic hypertension, which requires lifelong vigilance and treatment. Williams syndrome is also a polyendocrine disorder. Some of the more common endocrine issues are listed here, but there are several others as well. Hypercalcemia is often first mentioned when people hear about Williams syndrome because it was one of the early issues mentioned back in the 60s. However, the other issues listed here are all more widely occurring, especially abnormal growth, which occurs in virtually every individual with Williams syndrome, and they are usually about 80% of normal stature. Hypothyroidism and diabetes are also common in adults, and early onset of puberty is very troubling for parents of young girls who often will still only be 4'4" or 4'5" at age 10 or 11 when puberty starts for them. Gastrointestinal findings in Williams syndrome are very prevalent and can be quite serious. Reflux and constipation are very common, especially in young children, but many individuals will require treatment for these issues throughout their lives. Diverticulitis occurs in many individuals and occurs much earlier than in the general population. My son's colon ruptured 2 years ago when he was just 29, and many others have ruptures even earlier than that. There are many documented cases also of rectal prolapse, which is especially prevalent in young children, and there are increasing reports of celiac disease in Williams syndrome. The musculoskeletal findings in Williams syndrome occur early with joint laxity and what are known as sort of floppy babies, but often eventually evolve into joint contractures. Infants and toddlers typically receive physical therapy for several years. And scoliosis, although less common, can require bracing and surgery to present spinal rods in individuals. Lordosis is especially seen in adults with Williams syndrome, and flat feet are also common. And all of these issues tend to slow individuals down quite a bit as they get older. The Williams syndrome cognitive profile is unique. Although there is global cognitive impairment, the areas of strength and weakness are widely disparate. The typical full-scale IQ of 55 to 65 is often comprised of verbal skills in the 80s and nonverbal and spatial skills in the 40s. Most individuals with Williams syndrome will function in the mild to moderate range of cognition. In addition to the medical and the cognitive challenges, many individuals with Williams syndrome also deal with psychiatric disorders. Similar to other challenges in Williams syndrome, these issues range from fairly mild to debilitating in severity. Many individuals who have issues, such as those listed here, require ongoing treatment. Often that's a combination of medication and behavior management for youth and medication and counseling for teens and adults. Although children and with Williams syndrome often have phobias and can have quite severe anxiety issues, these diagnoses are most common in the young adult and adult population. As a contiguous gene syndrome, Williams syndrome provides rich research opportunities. Research teams are looking at those with Williams syndrome to learn which genes impact the various medical, cognitive, and social characteristics that are common to those with Williams. Since many of these characteristics are also common individually in the general population, those with Williams syndrome are thought to be able it's thought that they might be able to help actually gain knowledge that will help those in the general population as well. Scientists can already attribute several of the characteristics seen in Williams to specific genes as shown here. And they are working hard to try to learn what other things are doing as well. Oops, what happened? What did we do? Just the last one.
David, could you put the last? To the last slide.
We want the last slide. Shown here are some of the characteristic facial features of Williams syndrome. Although individuals with Williams syndrome retain a familial resemblance, they also have many common features which result in a characteristic facial appearance. So much so that when they're in a room together, they all look related. Facial features will sharpen and become more pronounced with age. Some of the more easily recognized characteristics include a stellate pattern in the iris of blue-eyed children, epicanthal folds, periorbital fullness, small upturned noses, and full lips. Early reports of Williams syndrome often referred to the characteristic facial appearance as elfin in nature. As I mentioned before, there's currently no ICD code for Williams syndrome. And due to that lack of a specific diagnostic code, it's been impossible to determine the true frequency of this disorder and to identify people who could participate in research. Having a specific code for Williams will provide these opportunities. This will not only lead to the creation of surveillance, management, and treatment guidelines, it will help the scientific community find critical answers and about the many medical and cognitive challenges that impact those with Williams syndrome, and may also provide critical insight into the management and treatment of this syndrome. Williams syndrome, individuals with Williams syndrome experience medical, developmental, cognitive, neurological, and behavioral challenges throughout their lifetimes. Thank you.
Thank you, Terry. If everyone can turn to page 92. We are proposing to add Williams syndrome at category Q93 under creating new code Q9382 for Williams syndrome. Are there any questions from the audience? Moderator, could you open the phone lines?
All lines are unmuted.
Okay, could you close the phone lines, moderator? Nellie?
Nellie Leon, she's State American Hospital Association. Sorry, a little bit slow on the uptake here. Just want to get clarification that a lot of the information that you just presented, they're not all integral to Williams syndrome, right? So some patients may have some of the manifestations, but not others. And the reason why I asked, because from a coding perspective, we do have a guideline for coding syndromes. And basically what that says is that we're supposed to follow the index guidance when coding syndromes. And if there is not specific codes for the documented manifestations of the syndromes, then those could be coded. But if you do have a unique code like you're proposing, additional codes for manifestations that are not integral part of the disease process may also be assigned when the condition does not have a unique code. So I wanted to sort of understand, because I think I kept hearing you say may have this and may have that. So when you were listing all those manifestations, not every patient has them, right?
That's true. Not every patient will have everything, but most all patients will have many things. No one that I know has only one or two characteristics of Williams syndrome. My son has had 6 heart surgeries, has had scoliosis and spinal rods placed, has had his colon rupture, is small in stature, all of these things, and has the typical cognitive profile. So there are many of the characteristics that are pretty much specific to every individual with Williams syndrome, although then, that may be 20 characteristics, but there may be 30 characteristics, so some will affect fewer numbers, but there are many, many which are universal to all.
Is there a list somewhere that as a coding professional I could access to determine what's integral to all the patients, or at least most of the patients? And the reason why I ask is that with many of these syndromes, as a coding professional, it's a little bit hard to determine what's integral or not integral to a syndrome, so we can figure out whether we code these other things separately.
Yes, Dr. Pober has an article in the New England Journal of Medicine which lists pretty much all of the common characteristics, and there are others. Most of those that were shown in the slideshow I presented are those that are seen pretty much universally or close to it.
Okay, all right, thank you.
Mm-hmm.
Are there any other questions on the floor? Okay, thank you, Terry. I'd like to call up Ms. Shannon up to the podium.
Good morning. The next topic is Tarlov Perineural Cyst. And to provide the clinical background, I would like to invite Dr. Rudolf Stroht to come up at this time. Dr. Stroht is a neurosurgeon with Suter Medical Group and an adjunct professor of neurosurgery at Touro University.
Good morning. Thank you. My name is Rudy Stroht. I'm in Sacramento, California, and I just wanted to thank Rita Hires of the Tarlov Cyst Disease Foundation for inviting me to speak to you this morning about Tarlov cyst disease. So the definition, perineural or perineural cyst, meningeal cyst, a CSF-filled dilation of the spinal nerve sheath. They're usually sacral in location, about 95%, but they can also occur in the cervical, thoracic, or lumbar spine. And there's a female predominance, estimated 80% or more, 92% versus 8% in one study. The background of this disease, this has been known now for at least 80 or so years, pushing towards 100 years, was first identified by Isidore Tarlov, who was a neurosurgeon that was dissecting cadavers, and there were about 30 cadavers, and he identified in a subset of these cysts in the spinal nerve root, and this was published in 1938. And at that time, there wasn't clinical information identified associated with these cadavers, but he wondered if these could be symptomatic. About the same, about 10 years or so later, Rexed, independently not knowing about Tarlov's work, also identified these cysts and described arachnoidal proliferations with cyst formation in the human spinal nerve roots at their entry into the intervertebral foramina. Tarlov subsequently published a paper around 1948 where he had operated on a patient with a Tarlov cyst that had sciatica that had complete relief of the symptoms. And he was actually suggesting that this was an alternative cause of sciatica or nerve root shooting pain down the leg, in addition to the disc herniation, which had been described by Mixter and Barr. And Tarlov went so far as to recommend that surgeons, and this was before the time of imaging, if they didn't see a disc, to go ahead and explore the upper sacral area to see if there was a cyst available for treatment. This is a figure from Tarlov's original publication, and he classified various disease and pathologic stages of these cysts, from very small cysts to larger deletions. Neighbors had a classification published in 1988, and he classified these cysts as a type 2 meningeal cysts. And you can see this here on the left side of the diagram occurring at the dorsal root ganglion. And he was distinguishing these from other cysts, extradural cysts, also called a pseudomeningocele, a meningeal diverticulum that did not contain any neural elements, or also prolongation of a subarachnoid space over the root. Goyal classified cysts, and this definition is also commonly used. Various names appear in the literature: perineural cyst, Tarlov cyst, Rexed cyst, nerve root diverticulum or sacral cyst, pathologic cyst formation within the nerve root sheath at the dorsal root ganglion, located at or distal to the dorsal root ganglion, usually sacral, but may involve other nerve roots. The pathologic mechanism is still really unknown, thought to be a result of trauma and hemorrhage into or arachnoidal proliferation. Connective tissue disorder is also a very strong possibility in many patients with connective tissue disorders such as Ehlers-Danlos or Marfan syndrome exhibit these type of cysts. And microscopically, the cysts lining can contain nerve fibers or ganglion cells. And so this is a destructive process of the spinal nerve root and the spinal ganglion. A very recent classification that was published in the journal Neurosurgery, Kleekamp classified spinal duropathologies, and he identified as well these cysts, which were distinct. In his classification system, these are type 1 diverticula nerve root sleeves. There's a dural defect at the transition zone where the dura and peripheral nerve sheath meet. They have commonly delayed filling on contrast myelography. Nerve roots are inside, or they may be adherent to the cyst wall. And again, these cysts can contain neural elements such as nerve roots or ventral roots, or also ganglion cells. And in Kleekamp noted that there often may not be associated with low pressure symptoms, but this is a point which probably could be debated, and some of them probably do have communication or exudation of CSF, which would cause low pressure symptoms. Just to get an idea of what we're talking about, this is a Tarlov cyst seen in a sagittal T2 weighted MRI. There's quite a variety of morphology. This is a little larger one located at S2. The most common locations are S2, S3, and this is a medium size, and it demonstrates scalloping. You can see the remodeling of the sacral bone here and here. And this is a giant cyst, which has caused very dramatic remodeling of the sacrum, almost complete erosion of the sacral bodies. And here is another example. This is a parasagittal view that shows how the cysts are going through the sacrum and then into the presacral space or the pelvis. There are different descriptors that can be used to apply to these cysts. One is how many. Some of them only appear as solitary cysts. Other of these cysts are multiple. They can be small, less than a centimeter, medium, 1 to 2 centimeters, large, or I might propose a giant, greater than 4 centimeters. And again, the location is usually sacral. That's thought to be due to the hydrostatic pressure of the CSF. These cysts are filled with CSF, but can also occur in other areas of the spine. And the location, they can be within the central canal of the sacrum. They can be extended out into the foramina, which are the holes where the nerve roots exit, or they can also go into the pelvis, and that would be designated as presacral extension. So again, the etiology, we don't know for sure. They are likely, some of them at least, inherited or associated with acquired connective tissue disorders such as Marfan's, Ehlers-Danlos, Lupin's, or Sjogren's. Trauma has been identified as a possible mechanism due to arachnoidal proliferation from subarachnoid bleeding or from CSF sort of extravasating and pushing into the cyst and enlarging it. They develop in the space between the epineurium and perineurium at the dorsal root ganglion. They cause compartmentalized pressure affecting surrounding nerve roots. Radicular symptoms can affect S2 to S4. S2 to S4 supplies the pudendal nerve, and it also gives a parasympathetic supply to the pelvic splanchnic nerves that innervates the bladder and other pelvic organs. It causes erosion and remodeling of surrounding bones, and then the egress, or when they leak or rupture or slowly leak, could cause headaches and other symptoms of intracranial hypotension. The incidence is really unknown, and part of this is due to a lack of proper coding and also a lack of identification. Many of these, when they're seen on MRI scan, are ignored by radiologists or dismissed as not being clinically significant, and as a result, they're often are not included in a radiology report. In one study of 500 patients that had MRI for workup for low back pain, about 5% were found to have Tarlov cysts. And it's estimated that anywhere from 20 to 40% of these cysts may be asymptomatic. There was a study at Mass General that looked at over 10 million patient medical records, identified 73,000 that had lumbosacral or MRIs, and 1.8% of these, the radiologist actually reported the Tarlov cyst. So we know that at least 1.8% of, in this group of patients that were undergoing MRIs had these cysts. It's very likely that the number is larger than that since we know that they are routinely not reported on radiology reports. This is a study that we did, just a small sample of 20 patients, but looked at the types of symptoms that these patients have. So pain up at the top, urinary frequency and urgency, not unexpected based on the anatomy, radicular pain, fecal symptoms, lower extremity numbness, urge incontinence, sacral pain, incomplete voiding, leg weakness, nocturia, vaginal, rectal, perineal pain. Many of these symptoms may not be reported to a doctor, especially by a female patient. Painful voiding, insensible urinary loss, and other, it's been also associated with persistent genital arousal syndrome. There are some publications to this effect, erectile dysfunction in males. This is a slide that I got from the Tarlov Cyst Disease Foundation, and this just lists, I won't go through all of these, but it lists the common symptoms that patients are reporting routinely that are associated with the Tarlov cysts. Imaging, X-ray imaging, probably low sensitivity, but there may be a lucency, especially if there's bone erosion. CT myelography, they may not fill, but this can be variable depending on the opening with the subarachnoid space. MRI of the sacral spine is the gold standard for diagnosis. If there's a question, a contrast study could rule out other pathology like a nerve root tumor. But many of the standard lumbar MRIs are usually insufficient. They don't go down far enough often to cover the area where the cyst pathology is seen. MRI of pelvis can be done, but again, that's not configured to identify the cyst optimally. And part of the problem with this is lack of a proper code to really know what you're looking for. There are some other adjuvant tests that have been done. These I would consider to be experimental. There have been sural nerve abnormalities seen on EMG testing of the nerves, and also urodynamic testing in the bladder. We did a small study which we presented at the Congress of Neurological Surgeons showing detrusor instability and urethral instability, both of which occurred or improved in a majority of patients after the Tarlov cysts were repaired and operated on. So differential diagnosis can include lumbar disc disease, a variety of other diagnoses which should be ruled out. And treatment is a work in progress. Observation, medical management, surgical obliteration is probably the most accepted treatment, and various techniques have been described. Fenestration using muscle flaps, nerve root imbrication, or wrapping with a dural graft material, which is the procedure that I do. This just shows an intraoperative photo what the cyst looks like at exposure. Here's an example of the cyst. Here's an example of the repair where the nerve is stitched back together and then wrapped. There's a fat graft here to take up the dead space, and then the bone can be recapped, or various methods can be used to reconstruct the back of the sacrum. So what causes misdiagnosis? The wrong MRI or insufficient MRI, failure to report the cysts. There is often a comment that they're incidental findings, which is a little puzzling, how that pattern has occurred in some training, but it happens. And this affects multiple systems, and so many patients are seeing multiple specialists, and so it tends to be a little bit of an orphan type condition where many medical practitioners are not taking ownership for it. There's a delay in diagnosis, again, for various reasons, and I think that identifying the problem and having proper coding and diagnosis is going to help. And this is another slide from the Tarlov Cyst Foundation, just listing the loss. And I think that this could be true of many medical conditions, but I think when there's a condition that's where you don't have accurate coding or you don't have broader education and support for the diagnosis, this kind of makes these problems worse. So the accurate diagnostic labeling will make radiologic identification easier. So when we scan through radiology reports or see the codes that are being coded for, we're going to have a better idea about what the incidence is. It will provide data to payers, increase professional and public awareness, facilitate clinical research, and also promote the creation of registries for this. And just the current coding is G96.19, which is other disorders of meninges not otherwise classified. And this could include an acquired pseudomeningocele cyst. Those are some of those other entities in that diagram that I had in the beginning. Spinal arachnoid cyst, and Tarlov cyst, but it's too general. An intra-arachnoid cyst is a completely different. It's intradural. The pathogenesis, the treatment is completely different. A pseudomeningocele also is an acquired collection of CSF outside of the spinal canal, also completely different treatment. And so having these all lumped under one ICD-10 category doesn't help. So that's all I have. Thank you.
So here in the room, are there any clinical questions for Dr. Stroh? You come back, yes, please.
Jeff Linzer, American Academy of Pediatrics. So this is a type of meningomyelocele?
No, that is a congenital disorder, form of dysraphism. So where you have spinal dura and spinal cord that's exposed due to lack of closure of the crest cell. Neural crest cells are not coming together. So this is there may be a congenital origin, but it's a completely different entity.
So, and I guess that's part of the issue. If this is congenital and is not identified until adulthood, I'm just wondering if this really fits more in a congenital part of the chapter as opposed to the nervous system.
Yeah.
You don't have, I understand it can be difficult to determine whether this is something that's acquired, is post-traumatic, or something that's just been sitting around as a time bomb since the person was born. And I guess you'd have difficulty actually being able to track that data even if you had a unique code.
Yeah, I wouldn't go so far as to say, to probably classify this as congenital. I mean, I would maybe compare this more to like cerebral circle of Willis aneurysms, which sort of crop up, can be seen in young children, but we think of it more as something that's acquired, a degenerative condition. So I would probably tend more to say this is a degenerative condition that could be predicated by certain congenital predisposing factors, but I wouldn't classify this as a congenital disorder.
Thank you.
Nellie Leon, Chief St. American Hospital Association. Thank you for your presentation. I agree that it would belong better in this section rather as a congenital chapter since we don't know the underlying etiology. But I think that more importantly, some of the comments you made about these cysts being identified in the diagnostic imaging where the physician may say incidental finding or no clinical significance, even if you do get a unique ICD-10 code, those would never be reported because it's part of our coding training and the rules, we are not allowed to code incidental findings of no significance. And so unless the patient has symptoms or it creates a problem, or radiologists and other physicians are trained to sort of understand the significance of this cyst, if they continue saying no, that this is incidental findings, no clinical significance, no matter how many codes you get, it'll never get picked up. So I hope you're planning to do some education of the physicians out there.
Thank you.
I'm Linda Holtzman, Clarity Coding. I just wanted to ask a couple of clinical questions, I guess. The history here was quite interesting. I have to say, though, that more to the point for a room full of coders, what am I going to see on the operative report and what am I going to see on the pathology report? Specifically, how is this going to be identified by the physician and the pathologist? Are they going to call it a Tarlov cyst? And if they do, are they going to call it some of the other names that you mentioned, such as a Rexed cyst or a perineural, whatever? What are the other names?
I think, well, Tarlov cyst is the most commonly
so we
accepted.
will actually see the word Tarlov
probably,
cyst.
Yeah, Tarlov cyst. Perineural cyst or, may also be many diseases have synonyms. So I think it could appear as either word, but Tarlov cyst I think is the most generally recognized descriptor of these entities.
Are some of the others that you mentioned used commonly enough?
I've never heard somebody call it a Rexed cyst. I mean,
that
was from the literature,
okay.
Some of the older literature that was used. But Tarlov cyst or perineural cyst are the two the two descriptors that are commonly used.
That's a key point from a coding perspective, as opposed to a historical one, because we need to know what we're going to see so we can index it and classify it properly. My other clinical question is, you mentioned that there's a possible connection to connective tissue disorders like Marfan's and some of the others. Is that something that we would see documented in the sense that a physician would say, notable, the patient also has Marfan's or...
In a subset of patients that were known to have those connective tissue disorders, but it would not be routinely identified in every patient having this.
Right. So, and not every patient who has those disorders, those connective tissue disorders, is going to exhibit this. So it's a question of coding it separately.
That's correct.
Okay. And then my last question is, what code did you say that people are using now? And how do you know this?
It's G96.19, which is...
G9619, so yes. Other disorders of meninges?
It's other disorders of meninges not otherwise classified, which includes some entities that are completely different and I think recognized as different, treated very differently.
I confess I've never actually seen this in all my years as a coder, so how do you come to believe that that's the code that's currently being used? Did they tell you?
That's the code that
Cyst spinal. That's where it's coming from.
Yeah.
Okay. Thanks. But to put it there, you say is then it's misclassified because this is intradural and the others are extradural, or?
It's just too broad of a term, I think, to be useful in describing this entity.
So the issue is that
it encompasses both that term encompasses both intradural pathologies and extradural pathologies, and it's kind of what we might call wastebasket type. It doesn't have enough, I think, specificity to accurately describe what we're talking about.
I just want to clarify. I'm not opposed to creating a new code, not at all. I just want to have a better understanding of where it should be classified. Should it be here where you're suggesting, or should it be in another code in G96 or something like that? But it sounds as if you're more.
I think it's probably in the right. I apologize. I'm not a coding expert, so
I'm sorry. I shouldn't.
I don't know all of the the ins and outs, but I think it's definitely
It's not a meningeal disorder, is what you're saying.
It's falling under, yeah, it's meningeal because it deals with arachnoid, CSF space, and so I think that it's in the right ballpark as far as where it would need to be.
I won't tax you with the coding stuff. I'll get you.
Yeah.
Thank you very much. Okay, I think we're good.
Thank you.
Thank you, sir. Okay, seeing no other individuals at the mic, I'll go ahead and we will look at the proposed tabular modifications on page 77 of the top. I'm sorry, we have one more individual.
Thank you. Hi, I'm Rita Hires, Executive Director of the Tarlov Cyst Disease Foundation. I wanted to address a little bit the congenital questions. The mean age group at onset of symptoms of these patients is 30 to 50. So we also know many patients who in the past may have had some trauma, who have had previous imaging of the spine with no Tarlov Perineural Cyst imaged. So we have some clinical evidence that it is something that in general happens with adults. It is an adult onset. From the categories of patients that we know from every continent except Antarctica, the vast majority are adults. Very few children, no known congenital diagnosis of this pathology. So, anyone have any questions about that? Comments? Okay.
Okay.
Thank you so much.
Thank you. Thank you. Okay. So looking at the tabular modifications that are being proposed at category G54, nerve root and plexus disorders, proposing to create a new subcategory G54.8 for other nerve root and plexus disorders with a new code G54.81 for Tarlov Perineural Cyst and a new code G54.89 for other nerve root and plexus disorders. Are there any comments or questions here in the room? Okay. Moderator, could you please, 1 second, please.
So you would consider this more of a disorder of the spinal cord or of the nerve root?
Spinal nerve, meninges.
Okay, so it probably actually belongs in probably the G95, other disorders of the spinal cord.
It's not spinal cord though. It's spinal. I would have to look and see. It's the covering of the nerve sheath. So it's
or the G96 with a specific code of G96 would probably fit in the coding continuum better.
I believe so.
So Dr. Linzer, could you please give us a quick summary of what came from that dialogue, please?
No.
Please.
So basically trying to figure out where it might fit better. If it's not exactly a nerve root or plexus disorder, if it's more of kind of this spinal cord type of area, whether a G95, 96 might be a better location for it.
Okay. 95, 96.
Just a comment. I mean, I think it's a nerve root disorder. There's arachnoid around the nerve root. That's meninges, and so I don't think it would be correct to classify this as a spinal cord disorder because it's not. There's no disorder of the cord. It's involving the coverings of the nerve root, so that would be a meningeal disorder. And the classification of Klecamp, which was recently published, talked about pathologies of spinal dura. So it's clearly a dural or arachnoid pathology, not a cord pathology.
Okay, thank you.
Correct.
Yes, I presume this is David Berglund, NCHS. I'm presuming that it would be involving meninges, and the issue is that the meninges have a fluid-filled cyst that then is impinging on the nerve root, and presumably that's what's causing the symptoms, so that would be the reason for classifying to nerve root?
I would not identify nerve root with spinal cord. I think those are different.
It's below the cord, sir.
Different things, and yeah. So I wouldn't cause. I mean, if you had something that was, well, I don't want to speculate. I mean, you could have pathology maybe in the thoracic spine that eventually affected the cord, but I mean, it's clearly, I think, on the side of the meninges, not on the cord.
Meninges, okay.
But yeah, I don't think we have a separate code area for meninges as such, so I think that's why we're looking at the nerve root category, that the category that's being proposed in here is nerve root and plexus disorders. So it's the symptoms would usually be involved with the nerve root being impacted by the cyst, as I understand.
That's correct. It's a nerve root problem.
Okay, thank you, sir. We'll take all of this back for consideration.
Where it's currently classified to G9619 is under the subcategory of disorders of meninges not elsewhere classified. So perhaps putting it in G961 as a unique code there would be a more appropriate place to locate it.
Okay. Thank you. One more. Go ahead.
Yeah, I have a question about the perineural cyst. Are all perineural cysts Tarlov cyst, or are there some that don't classify as that type of perineural cyst?
Perineural anatomically, so it's because they form around the nerve root sheath. The doctor's name.
Could you please come to the mic, please, so we can hear your response?
Yes. Tarlov is the name of the doctor, as Dr. Schroeder indicated, that they were first given the name of because he initially discovered them in cadavers. So perineural is the anatomical definition of this pathology. They form at the dorsal nerve root ganglion of the nerve root sheath. They do not form in the meninges, the dura mater, pia mater, arachnoid mater of the spinal covering. But they form at the nerve root sheath. But in answer to your question, they normally are written and published about by those who do have expertise in this diagnosis as Tarlov/perineural. Okay. So both names are used, but anatomically, it is perineural.
Okay. Thank you.
Okay, I'm sorry.
So that if there's a perineural cyst and the physician has not classified it as a Tarlov.
Can you get to the microphone, please, ma'am?
Yes, thank you. I'm sorry. If there's a perineural cyst and the physician has not classified it as a Tarlov cyst, is it the same thing? Yes. Should it be coded as a Tarlov cyst?
Yes. All perineural cysts are Tarlov. Yes.
Well, I can just make a comment. There are probably three entities that could occur, and according to the classification, Tarlov cysts were those that were, containing neural elements in their walls, either ganglion cells or spinal nerve fibers. Meningeal diverticulum could appear similar on radiographic imaging, and that's a blind pouch or diverticula of the meningeal sheath as it approaches the dorsal root ganglion. The other entity would be what's called a nerve sheath prolongation, or where you have a dilatation of the nerve sheath proximal to the dorsal root ganglion. So those are three entities that may appear similar, but would probably be all identified as perineural cysts, okay. Of which Tarlov cyst is one of them.
Okay.
So from the physician's perspective, and this is part of our problem.
Dr. Plinter, could you please speak in the mic?
No.
Please, please.
From the physician's perspective, and we don't teach our students and residents well in documentation, and where the coder's perspective is the problem, if the physician only documents perineural cyst, or if the radiologist only says perineural cyst, and that's all the coder sees, is that considered the same as a Tarlov cyst, so it would be considered an inclusion term, or are there differences in perineural cysts that it would actually be something different than a Tarlov cyst, so it could only be a Tarlov cyst if the physician specifically documents that term?
I'm going to need you to please come to the mic and speak so that everyone can hear you, especially those that are online.
I thanked Dr. Linzer for expressing what I was going to say. The question for us is, if we see the documentation that says perineural cyst, and that's all we see, should we code it to this new code you're proposing for Tarlov cyst? And if that's the case, then the technical point here is that under this new code, we should have a term that says perineural cyst. So if you don't see the word Tarlov, but you do see perineural cyst, it's the same code. And you're fine with those two going into the same code. Okay, that's the point.
Thank you. Thanks.
Yes, I would agree with that assessment. I mean, all of these are evaluated, the same way. It's not going to affect the, I think the treatment, the plan. These are maybe fine points, but I would fully support that.
Okay.
I understand. Yeah.
Okay. All right. Thank you. I'm going to go ahead and open up the lines, see if there's anyone. Moderator, could you please open the lines for any questions or comments?
All lines are unmuted. Hi, this is Dr. Erica Reamer, and of course I have a comment. So my first comment is, why don't we make G5481 perineural cyst and have Tarlov cyst as an inclusion criterion? Number two, I want to reiterate that if a patient comes in complaining of pelvic pain and they incidentally find this, you're not going to be picking it up. And number three, I have a question as to whether if a patient has known trauma, should they also be picking up a sequela of the trauma?
Sequela of the trauma in regards to the Tarlov cyst?
If the doctor were to document that they felt that this was secondary to the, the back injury from 3 years ago, would this actually be a sequela of the back injury?
Potentially. When you send in these comments in writing, can you please give us that scenario so that we could walk her through and see if it would be a sequela for that scenario?
Sure.
Thank you. Okay, I'm going to take one more comment if there's one here in the room, and then we're going to go to the next topic. And we ask that you please put these comments in writing and send to us, please. Was there one more comment? Or, okay, a separate.
Excuse me, may I just ask one more question from the phone?
Yes, please, go ahead.
Just listening to these various comments, I do agree that we should have some additional instructional notes, like use additional code notes or something to show whether or not it is associated with Marfan's or associated with a late effect of an injury. I also think, and I'll put all of this in writing, but I do think it might be useful for wherever the code is put that we might have some 6 digits to identify whether it is cervical, thoracic, lumbar, or sacral, because I think that the site does sometimes, always will be significant as far as what are the symptoms that are associated with the cyst.
Okay.
And if there are any other terms that are problematic, instead of making inclusion terms, we could always have another code for other perennial cysts and have Tarlov be its own. But if they're usually all the same, then they can all just be inclusion terms. But those are just some additional suggestions to make sure that if this is coded and it's associated with any other conditions, those other conditions are also noted.
Okay, great. Thank you. Please put that in writing and send it to us. Great comments. Appreciate the dialogue. And I'm going to ask if for any other comments on this topic, if you could please send that in writing so that we can move along. I think we still have.
I just wanted to say that is in the proposal to have a site-specific code for the to designate the cyst.
right? They did have that as a phase 2 part of the proposal after going forward with the initial code, is my understanding? Yes. Yes, okay. No other comments here in the room. I'm going to turn the podium back over to Donna Pickett.
Okay, I'd like to introduce the next speaker, who will be joining us for the discussion along with two colleagues. And this is not in your handout. You'll be seeing this on the screen, and it will be the discussion of forced labor and forced sexual exploitation. I'd like to invite Nellie Leon Chisen to the podium. And just as a reminder, when you're at the microphone, please do not turn your back to the microphone. It sort of defeats the purpose of having the microphone. And again, people are trying to hear, so you really do need to speak right into the microphone so people can actually hear you and so they can also be picked up on the feed. Thank you.
Good morning, Nellie Leon Chisen, and for a change, I'm at the big microphone as opposed to the one in the aisle. Oh, yay, thank you, my fan base. And I pay her to do that. Okay. So actually, this is a joint proposal that we worked with, we at the American Hospital Association, meaning me, worked with the Catholic Health Initiatives and the Massachusetts General Hospital Human Trafficking Initiative and Freedom Clinic. And this is a very important issue for us because the AHA has been very active as part of the Hospitals Against Violence initiative. We've been conducting webinars and highlighting member efforts in terms of trying to educate providers on how to identify patients that have been victims of forced labor exploitation or sexual exploitation. And so we found out that even if we were working with providers trying to help them identify these patients, they did not have a way to code them and distinguish them from other abuse patients that they may be seeing. So to help me with this, because as you know, I know nothing about the clinical stuff other than the coding, I've got with me Dr. Wendy Macias Constantopoulos, and she's a practicing board-certified emergency physician at Massachusetts General Hospital and assistant professor of emergency medicine at Harvard Medical School. And she actually educated me on why this is such an important subject, and also many of the questions that you ask and I ask at this meeting in terms of how will this be documented, how do we identify these patients, you know, what do physicians see and say. She educated me, and I think she's just wonderful, and I think that you're better off hearing from her than from me. So let me introduce that, Dr. Wendy, as I call her, and I hope she doesn't mind when I do that, but thank you.
Thank you, Nellie. Thank you, everyone, for allowing us to be here today, and to the committee for taking on this proposal. It's a very important one, I think, that so far we don't have proper coding for. And I'm going to talk a little bit today about why this is necessary. So to begin, I want to introduce the topic of human trafficking for those of you who may not be familiar with it. Human trafficking is an egregious human rights violation involving, and this comes straight from the United States Trafficking Victims Protection Act of 2000, which has been reauthorized several times since its initial legislation was written. But it involves the recruitment, harboring, transportation, provision, or obtaining of a person through the use of force, fraud, or coercion for the purpose of commercial sexual exploitation or subjection to involuntary servitude, peonage, debt bondage, or slavery. So to give you a little bit of background on human trafficking, this is something that has been in the works that people have been studying for over a decade now, for almost 2 decades now. It's understood to happen all over the world, including in the United States, and cases of human trafficking have been identified in all 50 states, in the District of Columbia, and in all U.S. territories. It involves both adults and children. And in the United States, it mostly involves exploitation for labor, for forced labor, or exploitation for forced sex. The prevalence of this is unknown. As you can imagine, it's a quite underground practice, but there have been studies done with some pretty good research methodologies that have estimated that there are 20.9 million people around the world trapped in forced labor or forced sexual exploitation. And that's just those 2 forms of human trafficking. There are other forms of human trafficking that occur around the world, but just looking at those 2, we're talking about 20.9 million people. This is an illegal industry that has profits upwards of $150 billion US per year. And there are multiple factors that predispose individuals to being vulnerable to being trafficked. There are multiple pathways by which individuals can be trafficked, so multiple mechanisms. And again, it affects both children and adults, men, women, transgender youth, and so forth. Some of the risk factors include child abuse, homelessness, identification as LGBT, family instability, foster care placement, minority or immigration group identification. These very same risk factors that predispose these individuals to trafficking are risk factors that are associated with some of its own trauma. So being a victim of child abuse or experiencing child abuse growing up, or experiencing family instability in the home, or getting kicked out of the home because you come out to your parents, these are all in and of themselves reasons why these individuals are traumatized from a very early age. It's this chronic exposure to traumatic stress that places these same individuals at risk for being trafficked and for continued polyvictimization throughout their lifetime. Trafficking itself results in extreme form of trauma due to its abusive, violent, and exploitative nature. While being trafficked, victims experience numerous health outcomes, negative health outcomes, including those related to the violence that is used to keep them under control, to unintentional injury related to the industries of labor in which they work, to untreated chronic diseases due to lack of access to medical care, infections, substance use, which is sometimes used to force control upon them, mental health illness, including suicide, and obviously the most extreme form of violence, homicide. We know from studies over the years that studies looking at survivors of trafficking, in those studies, trafficking survivors, about 50 to 87% of them report having access to medical care while being trafficked. And just as easily as they walked in through our doors, they walk right back out, unidentified and unassisted. 2/3 of them report coming into an emergency department for some form of injury, illness, or infection while being trafficked. There is a strong push in the medical community now for several years to train and educate healthcare providers about this issue of human trafficking, to train them on how to identify. And I think if we are going to continue along this line, we do need proper coding for this patient population. As I mentioned, the additional component of exploitation that is involved in human trafficking places the sequelae of trafficking into a category of its own. While exploitation falls along the same continuum as other forms of abuse and violence, exploitation is in and of itself a sort of more extreme degree of abuse and violence that involves a profound loss of autonomy, commodification of an individual as a property that can be bought, sold, and disposed of. And it adds that extreme level of trauma, which research has suggested is paramount to that seen in survivors of torture and survivors of other forms of crimes against humanity. The needs of this patient population, because of the extreme abuse and violence that they endure, is quite extensive. As you can imagine, and as trauma theory tells us, the sequelae of complex trauma are numerous, and the immediate response of victims to professionals attempting to help them, including health professionals, can often be one of distrust, anger, shame, and guilt. Responding to their broad, complex needs, both medical, psychiatric, as well as their social needs, requires an enormous amount of resources. Having codes to help us understand the extent to which these resources will be needed is critical to developing the strategies and mechanisms for funding to ensure that these resources are reaching this patient population. The ability to track the patients and the scope of their needs is key to furthering our epidemiological understanding of trafficking, meaning the incidence and prevalence of trafficking in the United States, as well as expanding our knowledge base through research of risk factors that could potentially facilitate early screening, identification of individuals and children at risk, of health outcomes that may require diagnostic and treatment efforts, such as HIV seroconversion, and of possible prevention strategies. The current lack of proper coding and lack of identification, unfortunately, feed into each other and thwart our ability to effectively respond to these victims and survivors. As the training of healthcare professionals continues to expand, a proper coding structure will allow the healthcare sector to identify opportunities and gaps in care and inform public policy to develop an infrastructure of resources and services more equipped to respond to the profound trauma and the broad spectrum of complex needs of this vulnerable patient population. Thank you.
Are there any clinical questions for our presenter? Moderator, could you open the line for questions, please?
All lines are unmuted.
Thank you. Okay, hearing no clinical questions, we'll move on to the code proposal. Now, a little bit of background about the proposal. We actually had received more than 5 different, separate, over time, proposals to address this important issue. The problem is we couldn't bring all 5, and each of them had different aspects that were important, but some of them were extremely detailed, and sometimes looking for information you may not typically find in your clinical documentation in the medical record. So the proposal here today, again, is the one that was jointly submitted by the AHA and other supporting organizations, but has been tweaked a bit to add some additional thoughts and perspectives from other groups, including the American Academy of Pediatrics. There is support for this, and when we are able to post the material, you'll see some of the other organizations and healthcare facilities that are also supporting the need for the code. And we also have an indication and a letter of support from the Office of Women's Health. Actually, the title is actually longer than that, so let me read it so I don't get it wrong. From the Office on Trafficking in Persons in the Administration for Children and Families and the Office on Women's Health in the Office of the Assistant Secretary for Health. So a lot of interest here, a lot of outreach and education going on as well. But as it specifically relates to the documentation that you'll currently find within medical records, as was noted in the American Hospital Association proposal, that this proposal is basically seen as a starting point for data capture. And as the industry healthcare industry becomes more familiar with the documentation requirements and the terminology, that there could be future presentations for C&M to actually expand the codes relevant to this topic. But we wanted to start out with kind of the here and now, knowing that we will likely do expansions in the future. So on the screen, and again, I'm not going to, for the sake of time, I'm not going to read through each and every line of what's here. 2 codes are being proposed under an expanded new subcategory, T74.5, forced sexual exploitation confirmed, and there would be 2 new codes added, one for child and one for adult. And then a new subcategory for forced labor exploitation confirmed, with 2 new codes being created, again, with the distinction between adult and child. And again, this is under the section for confirmed. In parallel, at T76, some of the existing codes, we're revising the notes to reflect the creation of the new codes. And then moving down the page, going to new subcategory T76.5, forced sexual exploitation suspected, and creating 2 codes, one for adult, one for child. And at T76.6, again, a new subcategory with 2 new codes, forced labor exploitation suspected, and again, the distinction between adult and child. Also, a new code at Y07.6 for perpetrator, and in this instance, the new code would describe multiple repeated perpetrators of maltreatment and neglect. Then at Z04.4, new codes are being proposed at Z04.43, encounter for examination and observation of victim following forced sexual exploitation, with an inclusion term suspected for sexual exploitation or sex trafficking ruled out, because again, this is the category for ruled out. And then Z04.44, encounter for examination and observation of victim following forced labor exploitation. And again, these are for circumstances where it's actually been ruled out. And at Z6281, a new code is proposed, Z62813, for personal history of forced labor or sexual exploitation in childhood. And then at Z91, personal risk factor NEC, a new code under Z91.4, Z9142 for personal history of forced labor or sexual exploitation. So that pretty much provides an overview of the, I believe it's 10 codes that are being proposed. And the reason that it's actually 13 new codes. The reason I'm specifically mentioning the 13 new codes is because among those 5 proposals we received, we actually had proposals that were requesting 100 plus or more codes. So again, we were trying to, for the here and now, represent what is actually being seen in medical records. We will also mention that some of the proposals we're really trying to put a lot of concepts into one code where it's appropriate probably to use existing codes, and so we didn't want to introduce the element of overlap either. So again, this is a starting point, something to build on. So would love to hear your comments on what is being proposed. And then, of course, if I need help, I'll turn to Nellie.
Jeff Linzer, AAP. So this is something that we worked on with WHO for I-11, as well as having worked with the International Center for Missing and Exploited Children. Yes, there's no question that these things need to be tracked. And we appreciate some of our other recommendations being incorporated into this proposal. The only problem I have is at the T74.2 and the T76.2, where those are the sexual abuse codes. And knowing how well our colleagues will code something or document something in the medical record, I could see where a person who suffers rape could be documented in such a way that it might be misconstrued as sexual exploitation, which we're trying to capture two different concepts. And I'm wondering if it would be better for the forced sexual exploitation to sit as a subset at the current sexual abuse codes, so that you expand that perhaps to a 6-digit, so that they are all sitting in the same general category and might be easier not only for the physician but the coder to locate, and then keep the separate code for the forced labor exploitation. Though some could argue that that is physiologic and physical, but I think that it is broad enough that it's reasonable to put it out as a unique code.
So Dr. Linder, let me make sure I understand. So you're saying an alternative might be to have these as inclusion terms at the existing codes and not create the new codes, or do both?
Put them as unique codes, but under, so expand, for example, T74.2, so you would have T74.210 adult sexual abuse confirmed, and then T74.211, for example, as adult forced sexual exploitation confirmed. That type of pattern, so that all the sexual abuse concepts stay in the same general subcategory.
That would be fine. I think that so long as they are within this section of codes of abuse, that would be fine. And one of the reasons why we wanted it in this grouping is that these codes have the ability to differentiate suspected from confirmed. And we also know that within the coding guidelines in the outpatient setting, if it's just possible, probable, we're not able to code it. And many of these patients may end up showing up in an outpatient clinic or in the emergency department. And so that's where we wanted the codes to have that flexibility. But I don't have a problem with them being under the T76.2 something else.
Right,
that would be okay.
But you do the same thing at the T76 too. So I was just using the T74 as an example.
Yeah.
So you'd mimic what you do to T74.2, where you incorporated the codes and gave them a unique identifier, and you just mimic that at the T76.2.
Yeah.
Okay, so that you don't have a T76.5 that's as a unique subcategory. It would be a unique subcode under
Yes, that's
sections.
fine. I think that would be fine.
Yeah, and then you can move your forced labor to 0.5.
Yes.
Hi, June Bronard, Intelligent Medical Objects, and I do agree, because I think that will help with some of the confusion potential with the terminology between around the sexual abuse and sexual exploitation. And the other question, if you could scroll up to the excludes notes, and I don't know if this had come up, but the excluding the abuse and maltreatment in pregnancy for this category, where there's consideration for additional information about when if the patient comes in pregnant, because now you're into the O section and not into here, and it happens to be because of this force exploitations. Were there also additional considerations for that, given on how to handle those situations with these?
You're absolutely right. We did consider that, but I'll be honest, we were really looking for something as a starting point, and we're afraid, because I myself have complained with when other presenters come in with a bunch of codes that may or may not be useful, and we wanted this as a starting point, and so we would have no objections to creating codes in the pregnancy section. I do agree that sometimes you're going to have that situation where you're going to have to figure out, okay, you know, we have a pregnant patient, and we also have this documented abuse. What do I do? And so we would be willing to consider having the additional codes. And actually, I really thought about that, but I was afraid that we would just sort of get shut down because we were so many codes. And so we really wanted to get at least get our foot in the door to start collecting this information. Thank you.
Makes sense.
Sue Bowman with the HEMA, and I agree with June's suggestion. I think that's a good one. I also had the same thought. I wondered if it might, to follow up on a couple points Dr. Linzer made, would be helpful to have a couple of maybe inclusion terms for human trafficking or something. Like he alluded to, I'm concerned that, you know, we've all seen this presentation, we know exactly what the point of these codes are, but I'm worried there might be confusion with other kinds of abuse or rape or so on, and they might use the exploitation code when that's not the kind of situation that these codes were intended to capture, and maybe some inclusion terms to help people understand which ones go to these codes, which ones go to the existing abuse codes would be helpful.
Thank you, Sue. Any other comments here in the audience? Moderator, could you open the line, please, for questions?
This is Dr. Reamer. I actually am very supportive of attending to the obstetric case as well. I think that I know that we don't like having too many codes at the same time, but I think that if you're going to do this, you'll have people going, well, what am I supposed to do? She's pregnant, and I don't know what I'm supposed to do with it. So I think we should do it now as well.
Thank you, Dr. Reamer. Are there other comments online?
Yes, please. I do have a couple of comments. Dr. Linzer alluded to the fact that they're looking at this in 11, but I think we need to first look at how it's being handled in 10, especially if we have a case that turns into a homicide and we want to be able to track it for mortality. Also, I don't think, we're talking about how many codes are being created. We don't need codes for perpetrator, and we do not need codes for ruled out. If we have suspected, then that's important. But if it's ruled out, then it's no longer in this population, and so we probably don't need anything for ruled out. And perpetrator codes for is if the trafficker is the patient, and that's also not a population necessarily that we're looking at. So I think it's possible to keep the proposal much simpler. But bottom line is I think we should do the best to make sure that it matches whatever similar categories we have in 10.
Thank you. Could you identify yourself, please? I don't think we were able to hear your name.
Amy Blum, National Center for Health Statistics.
Thank you.
Okay, so heart rate was 160.
Is there another comment on the phone?
Oh, sorry, no.
Okay.
I didn't realize when I called in that that's an NIH meeting. Oh. So,
okay. Moderator, you can close the line.
Today and tomorrow.
Okay.
Okay. Hearing no additional. Oh, one more comment.
Tawana McIver, LabCorp. Was the purpose of, just to follow up with the last person's comment, was the purpose of the perpetrator code to try to capture the perpetrator of the abuse situation for the patient that's being seen, or what was the thought in having that code added? Because perhaps there is some use in knowing...
You mean the existing codes in 10CM and the perpetrator code?
Well, for the one specific to this, was the purpose to sort of identify who is trafficking the adult or child, or who is perpetrating the act? Maybe a parent, or do you know what I mean?
Yeah,
Does that make sense?
We have already existing ICD-10 CM codes that identify many different types of perpetrators at different levels, whether it's someone that the victim knows, a family member, caretaker, and so on. So one of the questions that I had as we were kind of working through this was what distinguishes these victims from all the other abuse codes that we currently have. And one of the answers that kept coming back was that we're not talking about a single individual being abused, as horrible as that may be, being abused by a family member multiple times or someone they know. But the fact that these patients are different in that this is happening to them multiple times, many, many times, but different people, strangers. And so this was one of the distinguishing factors, so that even if there was no way to capture the specific type of abuse, we could identify these patients by saying, no, these are people that are suffering multiple repeated abuse from different people. So it was a little, it was a way of capturing a little more information if we didn't have enough information for the other codes.
I'll also add a little bit to that comment that the education and training of healthcare professionals is currently on its way, but I wouldn't say that healthcare professionals are already educated and trained about this. So a healthcare provider who sees a child, adolescent, or adult who potentially is being trafficked may not know the term exploitation, but may be able to document and code that this patient has described a situation in which they're being abused or maltreated by multiple people multiple times a day on a daily basis, because that's what trafficking is. So they may end up using that code. I think as we move along and we continue to educate and train healthcare professionals, this is why it might be that in the future we're looking at expanding this code structure, simply because we may learn more and our healthcare professionals will be more equipped with these, with knowledge of these codes and knowledge of exactly what human trafficking is. But that may be a code that a healthcare provider may use, where he or she may not know the term human trafficking, may not know the term exploitation, and may not use that code. And I realize that the coders are the ones that ultimately code the encounter as such, and the coders will also need to go through their own education of the issue. So we'll see, but there might be a situation where the healthcare provider does not yet have the language, but the coder does, and may be able to recognize that that this could be a case of trafficking, of exploitation.
Seeing no other questions, we're going to let Dr. Wendy have the final word here, and we will move on to our next topic. Thank you both so much. And so now I will turn the podium over to our medical officer, David Berglund, who will introduce the next topic. David?
All right, and we're next going to talk about Angelman Syndrome, and we will have that in our topic packets also. And I am going to just quickly turn the podium over to Dr. Wenhan Tan and let him talk with us about Angelman Syndrome. Dr. Tan, I'm sorry for a brief introduction. I'll let you tell a little more about yourself.
All right, thank you for giving us the opportunity to present our case to the committee today. I'm Wenhan Tan. I am a clinical geneticist at Boston Children's Hospital, and I also work on Angelman Syndrome as a clinical investigator. I am here today representing the Angelman Biomarkers and Outcome Measures Alliance, which is basically an alliance formed by the parent support groups as well as by clinical investigators and industry investigators. How do I advance the slide? Okay, excellent. So, okay, and is that a pointer?
Buttons at the top go forward and back. Or they should. You may have to point it down that direction or hold it up higher.
Okay, so so as I said, in addition to being a clinical geneticist, I am also involved in clinical trials in Angelman Syndrome. I run the Ovid-sponsored Angelman trial on a drug called Gaboxidol. I am also involved in a device trial looking at speech generation devices for children with Angelman Syndrome. And finally, we are also running a natural history study sponsored by the FDA. As part of one of my roles in the clinical realm as a clinical geneticist is to see a lot of patients with Angelman-like conditions. And we'll go through some of that in a minute, but I often get asked to consult on children whose clinicians had thought that they might have Angelman syndrome, but was found to not have Angelman syndrome. And it turns out that they actually have different, very distinct genetic syndromes. So Angelman syndrome, we now know, is a very well-defined, unique condition. It is one of the more common neurodevelopmental disorders, and the prevalence is actually twice as common as Rett syndrome, and it's almost as common as Huntington disease. Angelman syndrome is seen by a large number of different specialists in both the outpatient and inpatient setting. These could include neurologists as well as orthopedic surgeons, depending on the different clinical manifestations. We believe that there's now an urgent need to have a new ICD-10 code specific to Angelman syndrome, in part because there are clinical trials that are currently underway for conditions, for therapeutic products that are targeted specifically to treat Angelman syndrome. We'll go into the genetics of Angelman syndrome in a minute, but essentially it is now known that there are 4 different mechanisms that can genetic mechanisms that can all result in Angelman syndrome. Whoops. Sorry, this.
Buzzing problems there.
Okay, sorry. Whoops. Okay, sorry about that. So, so what is Angelman syndrome? So, as I say, it's a neurodevelopmental disorder in which all affected individuals have what we call core symptoms. So, these are severe developmental delay, movement disorder, which includes ataxia and tremors, as well as specific behavior that is characteristic of Angelman syndrome, such as their fascination with water. Moreover, one of the very important distinguishing features of Angelman syndrome that is different from many other genetic disorders is their lack of expressive language. And this is what distinguishes Angelman syndrome from many other genetic conditions that present with just severe developmental delay. Depending on the exact genetic cause, different subtypes of Angelman syndrome are also associated with different clinical presentations. Microcephaly, seizures, for example, are seen in many cases, but there are also other symptoms that you can see on the screen here that are found in only some but not all the different Angelman subtypes. So currently, Angelman syndrome is coded as a condition or deletion of a particular chromosome. So it is currently coded officially under Q93.5, which, as you know, is describes essentially other deletions of part of a chromosome. We believe that this is an incorrect definition of Angelman syndrome and an incorrect way to code Angelman syndrome, because not all cases of Angelman syndrome are caused by a chromosomal deletion. As a result, a clinician who sees children and adults with Angelman syndrome might not actually code Angelman syndrome as Q93.5 because they know that that particular child or adult in front of them does not actually have a chromosomal deletion. Consequently, they tend to code Angelman syndrome under their symptoms. So they may code, if a neurologist were to see this child or adult with Angelman syndrome, they might code them as someone with seizures. An orthopedic surgeon seeing the Angelman syndrome adult with scoliosis would code this as scoliosis. And what then happens is that you end up with Angelman syndrome individuals with a bunch of different ICD-10 codes, none of which are specific for Angelman syndrome, and all are coded under their symptoms rather than their condition. So one of the things that we have come to realize over the years is that although historically the first cases of Angelman syndrome individuals were found to be those with deletion, only 2/3 of those with individuals with Angelman syndrome actually have a deletion. 1/3 of the patients with Angelman syndrome have genetic causes other than a deletion, all of which result in a lack of expression of the maternally inherited copy of UBE3A gene. So we now believe that Angelman syndrome is really not a chromosomal deletion syndrome, but rather a single gene disorder caused by a problem, a lack of expression of the maternal copy of UBE3A. So Angelman syndrome, as I said, is currently coded under Q93.5, and you can see that there are a large number of chromosomal deletion syndromes that can be coded under Q93.5, including, in fact, Williams syndrome that we heard about this morning. That's caused by a deletion on chromosome 7, and there are a large number of other chromosomal deletions here. So why is it important to have a unique ICD-10 code for Angelman syndrome? This is because the treatment and the management strategies for Angelman syndrome are very different from that for many of the other chromosomal deletion syndromes. So for example, if you have a deletion on chromosome 7, you can end up with cranial synostosis. You need to see the neurosurgeon. Well, Angelman syndrome kids do not need to see a neurosurgeon. They do not have problems with their skulls. If you have a chromosome 9 deletion, you can have basal cell carcinoma, type of skin cancer, which is never seen in Angelman syndrome. So there's no reason to think that a child with Angelman syndrome, an adult with Angelman syndrome for that matter, would need to see a dermatologist specifically for basal cell carcinoma. Same thing with chromosome 22 Q deletion, which has a lot of features that overlap with Angelman syndrome, but they have issues like a heart defect, which is not seen in Angelman syndrome, and therefore their management strategy is very different. So having a unique code for, unique ICD-10 code for Angelman syndrome, we believe will bring many benefits to both the Angelman syndrome community as well as to clinicians managing children and adults with Angelman syndrome. having a unique code, we believe, will allow us to access, or allow the parents to access disability benefits. Currently, because we do not have a unique code for Angelman syndrome, there are parents who find it difficult to get services for their children with Angelman syndrome. In contrast, Rett syndrome, which has its code, because they have a unique code for Rett syndrome, they can access communication interventions which these kids benefit from. The other problem with not having a unique code for Angelman syndrome is that we do not really know the true prevalence of Angelman syndrome. And that hampers epidemiologic research. It hampers provision of services, because how can a service provider decide how much services they need to allocate to Angelman syndrome unless they have a really good, accurate estimate of the prevalence of Angelman syndrome? And we believe that by having a unique code, and if everyone starts to use this unique code for Angelman syndrome, we will now be able, over time, to gather enough epidemiologic data to come up with these answers. As you have heard, we now have clinical trials that are currently underway for treatment of Angelman syndrome. Once we have these products on the market, we will need to be able to track their long-term outcomes, the efficacy of the outcomes, to know whether it really works in the real world. And having a unique code will allow us to do that. And this applies not just to clinical trials, not just to drugs, but also to behavior interventions, to device interventions. We are doing a clinical trial looking at speech-generating devices. Are these devices useful? So it cuts across the entire spectrum of healthcare interventions. As I've said earlier, there are different subtypes of Angelman syndrome. And we now know that some subtypes of Angelman syndrome, for example, those caused by something called uniparental disomy, meaning you get two copies of the father's copy of chromosome 15, those kids are at increased risk for obesity. And that is really important to know for the clinicians, because if you are seeing a child with Angelman syndrome due to uniparental disomy, you need to intervene with dietary management, with obesity management earlier on. Similarly, we know that most of the children with deletion, the 2/3 of children with Angelman syndrome due to deletion, are at very high risk for seizures, and therefore you need to be very aggressive about seizure management right from the beginning to prevent long-term complications. So the phenotype-genotype correlation is really important, and this is why we need a unique code, not just for Angelman syndrome, as you see later, a unique subcodes for the different subtypes of Angelman syndrome, so that we can start to code and track these subtypes carefully. We are also in the process of developing protocols for standard of care. And by having a unique code, it will now allow us to identify Angelman syndrome as a unique condition deserving of its own standard of care. And finally, recruitment to clinical trials is important. We now have an increasing number of patients who have been diagnosed with Angelman syndrome. If we can go through their medical records, we can go through the hospital health records and identify those patients using this unique code, we will be able to identify these patients who may be eligible and benefit from clinical trials. As I said earlier, having a unique code would also encourage us to have development of specific treatment protocols. So developing anti-epileptics. We now know that certain dietary treatments, the low glycemic diet, for example, is very effective for the treatment of seizures in Angelman syndrome. In order for us to be reimbursed, in order for insurance companies to pay for this treatment, we need to have a unique code for Angelman syndrome so that they know with this code we can actually, this child should then qualify for a low glycemic index diet. Same thing with physical and occupational therapy. We know that they have problems with fine motor skills. They benefit from intensive occupational and physical therapy. Behavior therapy, using ABA therapy. We need to have a unique code so that we can say that these kids qualify and deserve to have ABA therapy. Same thing with speech therapy for the same reason. And as I mentioned earlier, having subcodes is important because different subtypes of Angelman syndrome, different genetic subtypes of Angelman syndrome are associated with different complications. So autism, for example, is seen in some subtypes of Angelman syndrome, not in all. As I said earlier, uniparental disomy kids have early onset obesity. And seizures, they are more prevalent in those with deletions. So I think it's also important to note that the treatment for the different subtypes is different. So if you have seizures due to a deletion, benzodiazepines work really well. That may not work so well if you have seizures caused by Angelman syndrome with other subtypes. So there's now, as you know, better than I do, there are other rare genetic disorders like Angelman syndrome that have their own ICD-10 codes and their own subcodes for that matter. So Cri-du-Chat syndrome, caused by a deletion of chromosome 5, has a unique ICD-10 code at Q93.4, and Wolff-Hirschhorn syndrome has a deletion as a unique ICD-10 code at Q93.3. Turner syndrome is interesting. Turner syndrome not only has its own ICD-10 code, it has different subcodes for the different genotypes. And this is what we hope that the committee will agree with us on. So in summary, we believe that it is really important to have a unique ICD-10 code for Angelman syndrome because the symptoms for Angelman syndrome, as I've shown you today, are very different and unique among the rare genetic disorders. So as a clinical geneticist, I see a lot of different children with a lot of different genetic disorders. And I can tell you that when a child with Angelman syndrome walks in, I know that's Angelman syndrome because that's unique. That's very different from the other genetic disorders that I see in my clinic. And yet, I do not have a way to code that, to document that in a medical record in terms of ICD-10 code to say that this is unique, this is Angelman syndrome. And that's why we need that code. As I say, right now, the generic code, if you like, for that people use for Angelman syndrome is Q93.5, which codes for all chromosomal disorders, and that is not always true. A third of the kids we see with Angelman syndrome do not have a chromosome deletion. So it is misplaced, in our view, to have Q93.5 as the code for Angelman syndrome. And with a unique code, we will be able, it will also help us develop new treatments and facilitate recruitment into clinical trials. It is also important to have subcodes because of the different manifestations that are unique to the different subtypes of Angelman syndrome. And there are, in the future, we believe that there will be therapies that will be specific to Angelman syndrome subtypes as opposed to saying this is just a treatment for Angelman syndrome. Thank you very much for your attention.
Thank you. And let's open the mic for questions here in the room.
Yes, I just had a question with regards to.
Can you identify yourself?
My name is
audience?
Elizabeth Kohler, and I'm an endocrinologist here at CMS. So the question I have is, I know that there are a number of different syndromes in which the parental heritage makes a difference, and it's called imprinting. And so, and I'm not sure if it directly applies here, but the question is, if you have a situation in which you basically have the same genetic situation, but it depends on who the parent is, would there be any consideration when you're setting up codes that you would acknowledge the other syndrome, which sometimes has a completely different clinical presentation and often goes under a different name, so that someone could actually understand, you know, if you end up having, so that there's a recognition that that the conditions are actually linked. It's just which parental gene was passed.
Well, we don't have a way of recognizing that in the coding system. Certainly, Prader-Willi is known for this. Shall I let you talk about that briefly?
Right. So thank you for that comment. It is true, it is an imprinting center and is an imprinting disorder. And historically, there are individuals who have sort of seen Prader-Willi as the mirror syndrome, if you like, of Angelman syndrome, because Prader-Willi is caused by a loss or deletion on the paternal copy of chromosome 15. Now, I would say that as a basic science geneticist, I think that's there is some interest in that. However, as a clinician, Angelman syndrome and Prader-Willi syndrome are two completely different disorders. They have completely different manifestations, different problems. They are managed differently. And what I actually tell my trainees when I'm training them in genetics is that we really should think of Prader-Willi and Angelman syndrome as two completely distinct disorders. They just happen to be on the same chromosome, one from the father, one from the mother. But I do not think that they should be seen as being related in any shape or form. So I would propose that we do not, from a coding perspective, that we see them as distinct disorders, and one could of course make an argument that Prader-Willi deserves its own code, but that's not what we are here to represent today. But certainly I would not be in favor of linking Angelman syndrome with Prader-Willi syndrome, because I think that just adds to the confusion for people to think that they are actually somewhat related.
Okay. Other questions?
I'm Linda Holtzman from Clarity Coding. I wanted to ask you to repeat a certain point. I think I missed it. You said that Angelman syndrome is not always due to chromosomal deletions. Okay, so sometimes it is due to a deletion, correct?
Most of the time.
What else is it due to, specifically? Something about...
I thought we'd mentioned those, but I'll let you say that.
Right. So the underlying mechanism, biological mechanism that results in Angelman syndrome is a loss of, we'll call it a mutation in very broad terms. So for this purpose. So it's a mutation in the UBE3A gene. Now, each of us has 2 copies of UBE3A gene, as you know, and 1 copy we inherit from our father, 1 from our mother. In Angelman syndrome, what happens is that you're missing, or you have a mutation in the copy of UBE3A gene that you inherited from your mother.
So that sounds like a deletion.
No, because you can have a mutation, you can have a spelling error in Angelman syndrome that in the UBE3A gene that results in Angelman syndrome without a deletion. The gene is still present, but there's a spelling error.
So
whereas a deletion
what would that be called then? Sometimes it's a deletion, but
sometimes
then we have
it's
something called and I'm not a geneticist, I don't know anything about it, but sometimes it's also, there's something called a monosomy.
Okay. So let me go back to the slide.
Okay. Tracy, can you flip back to the slides?
So I know I skimmed through this. I'll go back to that slide.
Yeah,
I think it goes back. Whoops.
So for example, is it...
Reopen the slide, I think.
Sorry. It's easier to sort of see it here.
The reason I'm asking this question...
Yeah, so this is...
Okay, so it's disomy?
Okay.
Thank you very much, Dr. Berglund, I appreciate that. So it can be a disomy?
It can be a uniparent, so there are 4 different mechanisms.
Okay.
Okay, the most common is a deletion.
Deletion, okay.
That accounts for 2/3 of cases. Then you have 10% of the cases are due to a mutation, a spelling error on the gene.
An imprint issue.
Yes, I mean it is an imprinting in that only the mother's copy is normally active and the father's copy is silenced. That's the definition of imprinting in this particular instance. So 11% are due to a mutation. 7% are due to uniparental disomy. What that means is that instead of inheriting a copy of chromosome 15 from your father and a copy from the mother, you inherited 2 copies of chromosome 15 from your father and none from your mother.
Okay.
So there's no deletion, there's no missing segment. You just happen to have 2 complete chromosome 15s from the father and none from the mother. And then there are other rare causes, the 3% are really rare causes, where you can have a mutation in a different part of chromosome 15 that regulates the imprinting. So it tricks, the body thinks that you have 2 copies of UBE3A from the father when in fact you actually have a copy from the father and a copy from the mother. But because the body thinks, the cells think that you have 2 copies from the father, the other copy, the copy that's normally inherited from mother is not activated.
And then we have 11% where you just don't know?
And then, yes, exactly. So about 11% of individuals with Angelman syndrome do not have one of these molecular mechanisms, and it's possible that there are other causes of Angelman syndrome that we have yet to discover.
Okay, thank you. I appreciate very much you going through that for me. This then tends to a coding issue, which I will take up with Dr. Berglund. But thank you for explaining the, the background.
And this is a good question. Let's just keep this up briefly. Sorry, now that I'll say let's keep that up briefly, and Tracy immediately, she started to take it down before I said that, sorry. I was going to look at this briefly and note, when we are talking about this then, the one of the issues that might come up is what sort of genetic counseling should these people get, and we can, if we go back to that slide, you'll notice that certain of those he noted possibly inherited. Now the deletions, usually those are sporadic, meaning usually you won't get that as an inherited thing. It's something that just happened one time. There was this deletion. But it's not something that you're going to have to worry about for a parent if you're having another child. On the other hand, the other ones, some of them you do have to worry about, and that affects the genetic counseling that's needed. So it was noted here, 11% are from mutation on the maternally imprinted UBE3A gene within the Angelman deletion region. So in this case, these are single gene issues that cause the same kinds of symptoms and problems, but those are possibly inherited. So the things that you have to do for the family, for the parents, as well as for the baby here, the things you have to do to counsel the parents then can be different also. So it makes a difference that way. Now the other ones, the 3% from the imprinting, so basically you got the gene from both mom and dad, but the gene you got, or the set of genes you got from the mother were turned off. They basically were acting as if they were the same as the ones from the father instead of being different that way. So basically then there's a few differences, and the way that this is handled it affects a few different things. So that's a part of the impetus for asking for different codes, as it were. Now, just going on to that, I'll come back to that when I'm going over the coding, but let's go on now and look. Do we have further clinical questions? Or go ahead, actually.
Hi, I'd just like to make a comment. I'm going to read because sometimes I get a little emotional, but I will.
Go ahead and tell us who you are for everyone
yes,
in the audience.
My name is Terry Jo Bichelle. I'm a neuroscientist. I'm also a former nurse practitioner. But most importantly, I'm the mother of a son with Angelman Syndrome. This is why I have to read, because this is where I get emotional. When my son was diagnosed with AS, the first thing I tried to do to find out were what were the greatest threats to my child? What would cause him to be hospitalized? What would cause him to die? What dangers could I prevent? And what kinds of things could I prepare for? So that was 17 years ago, and we still don't know the answers to those questions. I can look up case studies on PubMed. I'm great on PubMed. And since Facebook came along and we have so many families on Facebook, I can do surveys of families and ask them what sends their kids to the hospital, what sends our kids to the morgue. But really, we don't know the answers to these questions. And the reason we don't is because we don't know how many people there are with Angelman syndrome in the population. Having an ICD-10 code would help us get this number, and it would help us answer these questions. Over the years, since my son was diagnosed, I have met many hundreds of people with Angelman syndrome, and many of them actually look similar to each other. As Dr. Hahn said, when they walk in, sometimes you know right away they have Angelman syndrome, and virtually none of them talk. But after the first impression, people with Angelman syndrome can be very different from each other. Some have terrible, intractable seizures, and sometimes people are lucky and they don't. Some never learn to walk. Some walk really well and then lose the ability to walk. Some sleep, some don't. Anyway, they can be really different from each other. And many of these differences break down by genotype. These genotypes that cause Angelman syndrome in the first place. My son has a class 2 deletion. We didn't mention in the presentation the different classes of deletions, but that also makes a difference and is also part of our request. A diagnosis of deletion-positive Angelman syndrome comes with a virtual guarantee of epilepsy. Rather than waiting powerless for the first seizure to hit, we prepared ourselves, my husband's a doctor, with rescue meds, and we never left the house without those rescue meds in the diaper bag. Thank God we had the medications with us when he had his first seizure, and we were able to administer it right away. I have seen children with Angelman syndrome get severe brain damage and even die from their first seizure. If we had an ICD-10 code for Angelman syndrome, we might be able to get doctors to automatically prepare for those seizures to happen. My son's been lucky since then in terms of seizures overall. He walks, he feeds himself, he goes to school, but we were sort of surprised out of the blue when he developed scoliosis. He still has sleep problems, behavior problems. We found treatments that help him, but some of the treatments that help him don't always help other kids with other genotypes. And some of the treatments that help those kids don't help my son. Having these ICD-10 codes broken down will help us be able to treat these kids properly. If there were an ICD-10 code, we could, for Angelman syndrome, broken down by genotype, we could start to understand what risk factors there are, for all these patients, and what treatments might help, and what medications should be kept in the diaper bags for all these kids. These codes will give us answers to these questions. It will help us, and it will help our clinicians improve the quality of care for our kids. And I just thank you so much for listening to me blather on. So thanks.
Okay. Thank you. All right. Do we have other clinical questions at this time? Seeing none, we will move to the coding, and we'll open the mics for questions from the audience, from the phone audience later. Let's look at our options here. We are actually proposing two different options here at this time, and these do not go into the level of detail that was requested, but there are two options that I'll look at. Option number one is at Q93.5, other deletions of part of a chromosome. It's proposed to add a new code, Q93.51, for Angelman syndrome, and a new code, Q93.59, for other deletions of part of a chromosome. So basically, all other deletions would continue to go to the 0.59. Angelman syndrome would have a single new code at Q93.51. Tracy, let's go to the next page then and look at option 2. Page down a time or two. There we go again. Okay. So option number 2 proposes a similar expansion for the initial part. We would have the Q93.51 for Angelman syndrome and 0.59 for other deletions, but we would further expand at 0.51 and propose creating new codes, Q93.511 for Angelman syndrome due to chromosomal deletion, 0.512 for Angelman syndrome due to paternal uniparental disomy, paternal UPD, 0.513 for Angelman syndrome due to imprinting defect, 0.514 for Angelman syndrome due to UBE3A mutation, and 0.518 for Angelman syndrome due to other cause, with an inclusion for Angelman syndrome where testing does not identify a genetic abnormality, and a 0.519 for Angelman syndrome unspecified, if you just know it's Angelman syndrome and don't have more than that. Now, as was mentioned, there are different classes of chromosomal deletion. As it came to us, this request did ask for separate codes for the class of chromosomal deletion. It's not as clear to me how often we would have that level of detail clearly in the diagnosis part of the chart, and I'm not entirely sure about even this level of detail. This does go beyond what we usually have considered, but it would have some potential for clinical utility, definitely. And Angelman syndrome, let me note, Angelman syndrome, while it is one of the rare disorders, it's one of the much more common of the rare disorders. So the numbers of cases that we would have for this would potentially be supporting more codes. So it's something we are certainly looking for public input on. We do ask for input. The original request was to grab a top-level WHO category, Q94, and use that for Angelman syndrome and expand there. WHO generally wouldn't approve or like us to do that sort of thing, and so we did not propose to do that in this proposed expansion. But I think we do have certainly room for some further expansion with 6 characters here, so it's something we certainly can consider. Whether it would be better to go with a single code for Angelman syndrome or to go with more details such as what's shown here or even more beyond this are things we certainly are happy to hear public input about. And with that, I will ask for questions and open the mic for Nellie. Tell us who you are.
Still Nellie Leon, Chastain American Hospital Association. All of these syndromes are very difficult for coders to figure out where they need to go unless there is a inclusion term, index, guidance, and so on. So I think that there is value in being able to identify this condition. And I know that traditionally, when we do expand the codes and create unique codes, we try to stay within the same category, at least, of where it was originally placed. And I have to admit, I didn't know enough before to know whether this is deletion syndrome or not. If you have it in the classification and I see it there, it's enough for me. But after this very thorough presentation and the clarification, see Linda, I mean, she can sit 2 rows behind me and we're still like sending brain waves to each other. I have a concern about putting this code in a section that very specifically says deletions are part of a chromosome when we know that not all of these cases involve deletion of a chromosome. So I guess I was looking for input from perhaps you can share, whether WHO would have any objection to putting it into something a little more generic, like we do have Q99, which is other chromosomes that
if we were going to do that, I would probably contemplate giving it its own letter or something to, so that we wouldn't be stepping on anyone at WHO's toes. Yeah, that's something we could contemplate. In ICD-11, there has been a rather thorough restructuring. We could consider other options that way. So it is something we can consider. This is where it is put consistent with ICD-10, but on the other hand, something like Prader-Willi syndrome, which we just mentioned, which is the same area being deleted, that is not in the chromosomal deletion section either. So we do like to be consistent with WHO as best we can. In this case, basically, we would separate the things that are from deletions from the things that aren't, and if you wanted to count them as something that wasn't a deletion, you could relatively easily tabulate things, at least, to some extent. But you do certainly make a very good point there. It is something that's always a little awkward, and this is in part based on how this was laid out many years ago before there was nearly as good of an understanding of the genetic underpinnings of it. And certainly we are moving to a little bit different approach. So it is something we're happy to take input on and to consider different options at least.
Yeah, because I can see physicians that know more about this syndrome arguing with the coder saying, no, this is not a case of a deletion of a chromosome.
Right.
Don't force me into a code that kind of groups them that way. And that's what I was trying to understand, what were some of the other options that you had been looking at in terms of where to place the code.
Well, and we partly were just putting it exactly where WHO has had it and where it's been classified so far in ICD-10 CMs. And as was noted during the clinical part of this, now some doctors might say, well, it really doesn't belong in a code that's titled other deletions of part of a chromosome because this case isn't a deletion. So some people may have been coding it somewhere else, but since Angelman syndrome is indexed and included at the Q93.5, it's supposed to be coded there even if it's from something other than a deletion. Although that is a bit of a problematic circumstance to say the least, yes.
And I guess, Dr. Tan, would you have any strong objections to have it grouped in something that is not quite right for about
they were requesting to be somewhere else. So,
Right, so thank you for your comment. So first of all, I wanted to thank you for highlighting the inheritance issue. That is a very big issue. I can tell you that we have, even in my own clinic, multiple families with Angelman syndrome due to UBE3A mutation where the parents have multiple children with Angelman syndrome. So recurrence risk in fact, if your mother carrying a mutation in your UBE3A gene, you have a 50% chance, 1 in 2 chance of having a child with Angelman syndrome. So we counsel them on that. Whereas if you have a deletion, your chances are well below 1%. It's really, really slim. And if you have something like uniparental disomy, it's even lower. So the recurrence risk for the different genetic subtypes and the type of genetic counseling that they would require is very different depending on the subtype. In terms of whether we'll go into these sort of details in clinical settings, absolutely. So if I see a child with Angelman syndrome and I do first-line testing and I say this has Angelman syndrome, I'm obliged as a geneticist to actually define the subtype of Angelman syndrome precisely because without that, I would not be able to counsel the family properly on their recurrence risk. In terms of deletion subtype, most individuals with Angelman syndrome who have a deletion today are diagnosed by something called chromosomal microarray, which is a way of looking at missing segments of chromosomes. And with standard chromosomal microarray that's available today, we can absolutely distinguish between class 1 and class 2 and other, what I would call atypical deletions. So, as part of our request, we had asked for deletion subclasses to be coded properly, and that is absolutely possible. Vast majority of the children I see in my clinic, I know whether they are class 1 or class 2. And I agree with you, Nelly, that I would not personally feel comfortable having Angelman syndrome classified as a chromosomal deletion syndrome because it really is not a chromosomal deletion syndrome.
All right, thank you.
Thank you.
So I think that I'm a lot taller than Nellie. So I think since Angelman syndrome is an inclusion term at Q93.5, we really don't know the numbers. So putting it into a unique code wouldn't necessarily be a problem. I can understand the WHO issue, but I think because the possibilities with 10cm, you could, for example, make it Q9A.
And we would consider that if we're wanting to get something at a higher level. Though we might consider creating something else as a broader group at a Q9A that we could place it into that might potentially be used for other things additionally, but I won't.
And I think that would be a very reasonable, reasonable use of the characters. The clinical question I have, though, is how easily are these different subtypes identified so that when a child has genetic testing performed, and we're talking about standard genetic testing, is all of this information can it be reported off a standard genetic test? Or are there other types of more specialized genetic tests that would be needed to identify some of these subtypes?
And I imagine one of the questions that might come up is how often will the doctors document exactly something that'll let them choose something other than the 0.519 Angelman syndrome unspecified? So I should let you answer those questions.
Thank you. Those are great questions. So let me give you a little bit of historical background on how we in clinical genetics actually identify genetic syndromes. So traditionally, chromosomal deletions were the easiest type of genetic abnormality to identify in a lab because you could do something called chromosome analysis, and then in the 1980s we had something called fluorescent in situ hybridization FISH that then allowed us, and then subsequently chromosome microarray that allows us to define genetic syndromes caused by chromosomal deletion. Now, over the years, people have found that a lot of chromosomal deletion syndromes, Angelman syndrome being one of those, are actually not caused by a deletion, by a loss of multiple genes, which is really the definition of a chromosomal deletion syndrome, but caused by a mutation in a single gene. So for example, there's a condition called Clifton syndrome, caused by a mutation in EHMT1, the gene. And for many years, we thought Clifton syndrome was a chromosome deletion syndrome because people were only able to do chromosomal analysis to look for kids with Clifton syndrome who had a deletion. But over time, we now know that even if you have a mutation in EHMT1, you can result in Clifton syndrome. And I think this speaks to your point that I think having a code like Q98 that encompasses other genetic syndromes that may or may not be caused by deletion, but some subtypes may be caused by deletion syndrome, has a lot of merit to it because I think that would allow us to expand.
But I guess
now, in terms of genetic testing for Angelman syndrome, what I do is if I see a kid with Angelman syndrome, the first line testing, and this is all standard clinical testing in clear approved lab, and vast majority of insurance companies will approve this, I will do something called a methylation analysis. Methylation analysis will tell us, will identify about 90% of individuals with Angelman syndrome. So this would, actually about 80% if you exclude the 10% without a genetic cause. So it will tell us whether it is a deletion, or, well, it will tell us if it is if the methylation is abnormal. It will tell us whether that it is either a deletion or uniparental disomy or an imprinting center defect. If that is abnormal, and we say there's a methylation abnormality, the next step is a chromosome microarray, which would then allow us to determine whether it is a deletion or a non-deletion. If it's a non-deletion, we then go on to do something called uniparental disomy testing, which again is standard part of the package that we offer to patients in genetic testing. And that will tell us whether it is a imprinting defect or a uniparental disomy.
So a community physician who's the most likely to see a patient and send off to one of the lab companies a genetic test.
Right.
That genetic test is not going to report the degree of specificity that you requested here, correct?
Well, so it depends on the lab that they send it to. So many of the labs that offer Angelman syndrome testing today would include both methylation and deletion analysis. So they would actually, at the very least, be able to know whether this child has a deletion or a non-deletion, meaning uniparental disomy or imprinting defect. Now, if they want to determine, if they determine it's a deletion, we know it's a deletion, and because it's a microarray test, they will tell you the size of the deletion. If the deletion comes back negative, but the methylation is positive, and this is as part of a single report, then our recommendation, of course, is that they come to see us as geneticists, and we can do the uniparental disomy testing. In all fairness, I would not expect a community pediatrician to necessarily do that second line of testing. But at the first line, absolutely, we should be able to distinguish between deletion versus non-deletion versus UBE3A.
Okay, thank you.
Okay, and I'll give a 5-minute warning here. We are going to make this our last topic before lunch, and we are going to break at noon, which is 5 minutes. So this will be our last topic, but we will continue to take further questions on this at this time. Linda.
I will be brief. I know that doesn't sound likely, but I I just wanted to follow up on Nellie's point. I'm absolutely fine with creating a new code for Angelman syndrome, and whether it's 1 or 5 or 6 or whatever, that's a separate issue. But no objection to having a new code. My question has to do with where it should be classified. And the Q9A is one possibility. Is there another chance, for example, to revise the title of Q93? I mean, we don't have any headings for disomy. In fact, there's not even any indexing for disomy or imprinting or any of those things. So could we just change it to monosomies, comma, disomies, comma, imprint, deletions, whatever, or something like that?
Well,
or have a note underneath Q93 that it also includes disomy and
things to consider, I suppose.
You don't sound enthusiastic.
Some of the things would tend to still fall outside of there. Some of the more common are the UBE3A mutations, I think, and those would be single gene disorders essentially, which then wouldn't really be chromosomal anomalies at all.
Monosomies, disomies, deletions, and other. How's that?
Imprinting defects. Yeah, in any case, there are thoughts on this. Now, Prader-Willi syndrome, on the other hand, is in a completely different area that's not even in the chromosomal defects, even though it, at least much of the time, is caused by a chromosomal defect as a deletion. So we've not everything is consistently always in the chromosomal deletion range, even if it involves deletions. So we can make a case potentially for moving things, but usually we like to keep them as best we can where WHO has them for purposes of comparability with statistics between different countries that use ICD-10 and our 10CM, of course.
I wasn't asking to move it. I wanted to leave it here and to make it easier to leave it here.
You were making that case, but just change the title so that it's more
or expand
properly
the title
included then.
so
and
that
that's it's always something to consider. But since the whole section here is on chromosomal anomalies, and then it would be a little hard to throw in something that's not even a chromosomal anomaly for at least part of it. And the disomies and the imprinting defects, I think we can certainly make a case. Those are chromosomal anomalies, but the single gene defect, we can't really make that case for that. But we wouldn't really want to pull that out and say, well, okay, we're going to have Angelman syndrome partly in this section, and we'll partly put part of it over there. That gets awkward when it's in multiple places too. So we do what we can to try to maintain consistency, but sometimes we can include things that might not obviously go there if that's a part of it. But usually we like to give extra detail in the codes so that we can then let people count them in separate ways if they feel that that's what they want to be able to do. So we'll keep looking at this. I will ask everyone to please put all of these comments in writing. And as I understand, our teleprompters and other things may go off soon. Can we have any questions from the phone lines? Can you open the phone lines for questions and comments? I'm not sure if we still have a moderator. Is our moderator still there? Are the phone lines closed at this point in time? Well, hearing nothing, I think we may break for lunch in a minute or so, but let me pass the podium back to Donna. Thank you, Dr. Chan, for being here, and thank you to each of you for your comments and questions about this. And Donna, I'll pass the podium back to you.
Okay, so we are going to take a 1-hour lunch break and then reconvene for the remaining topics. Enjoy your lunch. Bon appetit.